Dr. Lakmal.
Our next speaker is Dr. Lakmal Fonseca, MBBS MD, DPhil Luxon, MRCP. Dr. Lakmal Fonseca is a senior lecturer at the Department of Medicine, University of Ruhuna, and a specialist in internal medicine at Teaching Hospital, Karapitiya. Dr. Fonseca has a special interest in infectious diseases. He completed DPhil in molecular medicine and immunology at the University of Oxford, where he studied innate immune responses in dengue viral infection. He completed his overseas training recently at the John Radcliffe Hospital, Oxford, United Kingdom. Dr. Fonseca has published his research in index journals and has presented numerous abstracts and posters. So he will talk on HIV-associated opportunistic infections. Over to you, Dr. Fonseca.
Thank you very much. I hope everyone can hear me. It's a real pleasure to be back and in NHSL, where I trained as a registrar. So I was trained under the infectious diseases and acute general medicine team in Oxford, and Dr. Woodrow is the lead in the infectious disease. I had a really nice training and a good time in Oxford. So I'm going to touch upon HIV-associated opportunistic infections, which when I was a registrar here, I did not get much exposure, so I thought of talking on this topic. So moving on, what are opportunistic infections and why does HIV associate with opportunistic infections? So those are life-threatening infections that are seen in patients with advanced HIV who are generally not on antiretroviral therapy, and usually occurs when there's a weak immune response. And in HIV, it is mainly associated with a degree of immunosuppression, which correlates well with the CD4 count. So, but not only the count, the quality of the CD4 response is also important. If you look at the graph on your right side, you will see when the HIV infection sets in, it precipitously drops the CD4 count initially, but then the bone marrow and the hematopoietic system kicks in and increases the CD4 counts and to compensate in a compensatory mechanism. And thereafter, over many years, the CD4 count drops and causes opportunistic infections. So HIV directly attaches to the CD4 cell and induces cell lysis. And the degree of immunosuppression is related directly for the CD4 count, but also there are other factors which are contributing. A brief outline is I'm going to mention briefly about the CD4 count and what are the opportunistic infections and principles of managing opportunistic infections in advanced HIV, and also regarding 3 key opportunistic infections. First of all, with the CD4 count, there are on your left-hand side, you will see bacterial infections, pulmonary tuberculosis and extrapulmonary tuberculosis, herpes simplex, and usually multidermatomal herpes zoster could be associated with HIV with any level of CD4 counts. And when there is the higher degree of immunosuppression, when the CD4 count is less than around 200, you will see pneumocystis carinii or pneumocystis jirovecii, pneumonias, toxoplasmosis, cryptococcal disease. And with higher degree of immunosuppression, CD4 counts, when they drop below 50, then we'll see disseminated mycobacterial avium infections and also CVMV retinitis. So depending on the degree, the differential diagnosis might slightly change. It is a general rule that we can go for when we are investigating for infections. What are the principles in investigating infections in immunocompromised in advanced HIV? As you all know, the features of infection, symptoms and signs, and also the radiological findings might be very subtle and atypical. So then the key finding here is to go for full house and looking for all the signs and symptoms, looking for advanced modalities of microbiological sampling and radiological findings, gather as much as possible data before embarking on a diagnosis. So it is important to get the history and physical examination to identify basically localize the affected organ, and then have a broad differential diagnosis as there could be bacterial, viral, fungal, or parasitic illnesses which are leading to infections in the immunocompromised. You must also factor in the CD4 count as well, as the differential diagnosis might slightly change depending on the degree of reduction of CD4 count. And active investigation is the key. Have a low threshold in obtaining microbiological investigations. Some investigations might be invasive, such as bronchoscopy and going for a BAL, and look for higher modalities of treatment. If the chest x-rays and although negative, you can go for CTs and MRIs and higher degree of investigations. And also have a low threshold to go for obtaining tissue samples as well. In HIV, it is very important to have a multidisciplinary approach. Involve your microbiologist, HIV specialist, pharmacist, intensivist, radiologist, and also the people who are community follow-up. We are in our system, we are lacking a certain people that I mentioned, but it's imperative in the future to involve all the groups and in managing these difficult infections. And also lies closely with the lab to chase investigations. And also in all the stages of HIV, especially in Sri Lanka, tuberculosis should be considered. And we usually use Manto test, skin testing in Sri Lanka mostly, but it's important to look at IGRAS as well because it has more sensitivity when it comes to diagnosis compared to a Manto test that we use. And in all patients, do bloodborne virus screening, syphilis, and also other STI screens. I'll start with the case. A 59-year-old who had diarrhea, weight loss, and personality change over 3 months. He has been ill for roughly an year. He comes with predominant respiratory symptoms, shortness of breath, dry cough, and fever. There was bilateral crackles in middle and lower zones. And he was diagnosed of HIV like 2 weeks ago. And bloods, there is a marginal pancytopenia with a low lymphopenia, and there was a hepatitis, mild degree of hepatitis, and deranged renal functions. And sorry, I had my Slido in place, but I have to shift my presentations here. So I'll give you 15 seconds to think about some differential diagnosis. So differential diagnosis here, so we have to locate what is the organ system just predominantly involved here. But you will see from here, you will see the predominant organ system in the respiratory, but you will see there's a personality changes over 3 months. So maybe a CNS involvement, that hematological system is involved, renal system is involved. And basically it's a multi-system involvement with predominant respiratory presentation at this time. So we have to always think about conventional infections such as bacterial pneumonia and seasonal viral infections such as COVID and influenza, and also look at opportunistic infections. Pulmonary tuberculosis should be number 1 in our setting. Other than that, pneumocystis jirovecii, CMV, fungal infections, cryptococcal aspergillus, and mycobacterial avium complex infections. So we went ahead and did a number of investigations. If you can see from here, blood cultures were negative, chest x-ray was normal, and we went ahead with doing a CT. We showed a ground glass appearance in the middle and lower zones, and it was queried as whether it could be COVID. And COVID PCR was positive. The CD4 count was 10, so this falls into a category which is less than 50. And always we had to check for bloodborne virus and syphilis screen. It was negative. Look for evidence of TB with sputum and blood cultures, which were negative. And beta-D-glucan is one of the tests that we do there in the UK, which was found to be high. And I do not assume that it is available here. Yeah. So I'll come back to that later, what beta-D-glucan is. It is one of the important screening tests that we can use. So the diagnosis which was assumed here is pneumocystis jirovecii pneumonia because of the CT appearance and also the beta-D-glucan level. So we managed the patient with IV antibiotics, remdesivir and dexamethasone for COVID, and treated empirically for PJP. It is important to start the treatment well ahead rather than waiting for the final results, but it's important decision whether to treat or not. But in this case, with HIV, with severe degree of immunosuppression, with predominant respiratory symptoms, it was the likely diagnosis. We went ahead with bronchoscopy and BAL very early, and finally the PCP PCR came positive, and it was negative for TB PCR, and aspergillus antigen, which is looking for aspergillosis, was negative. So PJP or PCP, it's a fungal pneumonia which is occurring immunocompromised. The main risk population is the patients who are having low CD4 counts, less than 200. But not only the CD4 count, it's all the duration of immunosuppression. How long has the patient had reduced CD4 count? Both these factors are important. And also, if there's a history of oral thrush, that is also one of the most important features that we can ask in the history that would point us towards the PJP. Because if you see from the statistics, it's near people who are having oral thrush before has a 30% chance of having a PCP or PJP in the background of immunosuppression due to HIV. So if you see from here, this published in NJM some time back, the cumulative incidence of PCP is increased when the CD4 count is less than 200. These are the percentages. It's around 8.4. And if you go to the right side, this is the duration of having low CD4 counts. When the duration increases, the risk of PCP also increases. And when there's an oral thrush, it also increases, and the duration of you having diagnosed of oral thrush and not intervened, again, the PCP diagnosis, the risk increases. So PCP is an atypical fungus. It cannot be cultured, so we might not be able to culture the bug. And it lacks the usual architecture of the fungus, which is ergosterol. So we cannot give amphotericin or any other azoles. So main mode of treatment is cotrimoxazole, as it uses the folic acid pathway for its metabolism. And also it has beta-glucans in the cell wall, which is a component in the cell wall which is useful diagnostically to detect, suspect the disease well ahead. So I'll go to this slide first. So beta-D-glucan is the fungal cell wall antigen, and it has a very quick turnover. The results might be available within 24 to 48 hours, and it detects invasive fungal infections. But it not only be positive in PCP, it will be present in other infections as well. But when you're managing severe infections like this, it might give a lot of information beforehand and further plan the confirmatory testing. So PJP, the radiological findings, if you see in the first X-ray on your left side, it has the typical perihilar mid-zone shadows with the bat's wing appearance, and you will see ground glass changes in the CT, and they can also have pneumatoceles, which can later rupture and lead to pneumothorax. If a patient with HIV who's having pneumothorax is until proven otherwise, it should be a PCP. Investigations, usually it's best to do a bronchoscopy and BAL and perform a PCP PCR, which has a very high sensitivity and also a very high negative predictive value. And because of that, if it is negative, you can basically exclude the diagnosis of PCP pneumonia. And doing a sputum PCP will not be very reliable, as PCP can be a colonizer in the sputum and the upper respiratory tract. So its best sample would be going for a BAL. And one beta-D-glucan is another test that we can do in serum. If it is positive, it will give some evidence that it could be PCP, and we can go ahead with confirmatory testing. So if you can attempt to answer this question, what is the most appropriate investigation to diagnose PCP? What's the answer that would you give? Would you be happy to give an answer? So I would say the answer is 2. Beta-D-glucan CT chest and bronchoscopy. Sputum PCP PCR might not be the best sample, as I said. It might be positive when it is a colonizer. And bile fungal cultures in the third, we cannot grow PCP in the fungal cultures. And if you say there's a word called calcaflow, that is one of the staining that we can do in the bile specimens, which can identify fungal structures. So here, this is the calcaflow positive, which indicates there's a fungal components in the bile, which is not directly indicative of PCP. It indicates there's a fungus there. So, but it is not specific. So I would say a lung biopsy would be a bit invasive. So I think we can go for CT chest and bronchoscopy and bile, look for PCP PCR. So management, the gold standard treatment, as was discussed before, is the cotrimoxazole. It can be given as intravenous or orals. But if it is not available, there are second-line options that we can use. And the treatment is usually for 2 to 3 weeks. In case of HIV, it is important to start prophylaxis thereafter until their CD4 count improves more than 200. So then the same patient was treated with cotrimoxazole, and the patient improved. And later, the patient started having diarrhea and started spiking fevers, having abdominal pain, and a slight disorientation. What else would you do at this time? So the investigations were, we have done sputum AFB, which was a negative, and the CT was repeated. It showed bilateral ground glass changes, which has been increased. But interestingly, the beta-D-glucan, which I mentioned before, was trending downwards with treatment. But the patient's ground glass appearances in the chest are increasing, and the CT showed there's an additional development of colitis. Then maybe we should think of other infections. So the differential at this stage was, because the patient received broad spectrum antibiotics, whether it is Clostridium difficile, whether it is another bacterial gastroenteritis, the organism might be similar to the immunocompetent, CMV colitis, and any other parasitic infections that we see with HIV. And usually PCP is usually confined to the lungs. So it cannot cause colitis or CNS symptoms. So we thought of other avenues in the diagnosis and went for further testing. So initially, this patient had a CMV PCR, which was within the usually accepted range, but when we repeated it, it was very high, which indicates that the patient had a rapid rise of the CMV viral loads, and the other test that we have done was negative. So we went for the money. The important thing to diagnose CMV is go for a histological diagnosis, and went ahead for a sigmoidoscopy or colonoscopy, and we found evidence of CMV colitis. There was patchy ulceration, and there was and the biopsies was taken from here, and the diagnosis was disseminated CMV because there was worsening lung involvement with some CNS involvement as well. So briefly about CMV disease, it can present with abdominal plain body diarrhea with the general constitutional symptoms. It can present with pneumonitis, CMV retinitis, hepatitis, and can have encephalitis as well. And also importantly, they have gastrointestinal disease. Most of the important fact that we can remember is with gastrointestinal CMV, we might not see the general viremia. Sometimes the CMV PCR in the blood can be negative. So the gold standard, as I said before, would be histological diagnosis, go for colonoscopy, look at the biopsies, and there could be inclusion bodies, outside inclusion bodies that you'd see with the disease. So you can see the picture of the typical appearance of the alveolar inclusions. Then you could start on treatment for PCP as there was a rapid rise in the CMV viral loads. There was consistent evidence of pulmonary involvement with gastrointestinal involvement, and also there was some CNS evidence as well. So the treatment is usually IV ganciclovir, and in severe disease, life-threatening disease, you could consider immunoglobulins as well. And usually the treatment is given for 3 weeks until the CMV PCR becomes negative. Moving on to another case. This case is a 25-year-old who has been well 3 weeks back, a female. And she actually presented with 2 to 3 weeks history of headaches, diplopia, vomiting, and dizziness, and had worsening symptoms over the last few weeks. And on examination, she was found to have a left-sided 6th-nerve palsy. So it's possibly a false localizing sign. And general blood investigations were seen, and also the blood-borne viruses screen was requested and was found to have positive for HIV. Also, she had a transient loss of consciousness, increasing drowsiness on lying flat, and then we thought of some differential diagnosis. I'll give you 10 seconds to think about what are the differential diagnoses that would be entertained. Sorry, I don't have the interactive communication bit at this point. Yeah, so these are the differential diagnoses that we thought. So we have to always think about the conventional infections that we see in day-to-day life other than the opportunistic infection. So it could be a severe pyogenic meningitis with a lot of pus in the meninges. It could be cerebral venous sinus thrombosis. And in HIV-associated disease with immunocompromised state, you must think about TB meningitis, cryptococcal meningitis, and also toxoplasmosis. And also neurosyphilis would be one of the differential diagnoses. But here, because there are prominent focal neurological signs, we have to think about pyogenic or pus-forming, or bacteria, TB meningitis first of all, and also cryptococcal meningitis. So these are the investigations that was done later. A CT venogram and MRI venograms just to see whether there are any cerebral venous sinus thrombosis. In this patient, there was some subtle white matter changes which you might be able to appreciate, very subtle changes in the white matter, which are, which, as I said before, the radiological findings can be very subtle. But because the body cannot mount a good immune response, because usually they have very low CD4 counts. And the HIV viral loads were high. And again, this lady also had a CD4 count of 10 or 5 or that sort of thing, very low CD4 counts. And the blood cultures actually grow cryptococcal neoformans, and the cryptococcal antigen was negative. I'll come back to that. I don't think that's another test that we don't have it here. But in Africa and other countries, it is available as a lateral flow, which is a very useful test. The lumbar puncture was done. There were some cells, and the gram stain showed 3+ yeast. The opening pressures were high, and the TB PCR was negative, and the CSF PCR, which detects a panel of bacterial, viral, and fungal organisms, were positive for cryptococcal neoforms. So diagnosis here was cryptococcal meningitis. Coming back to the cryptococcal antigen, if you could see from the previous testing, blood cultures and the CSF was positive for cryptococcal neoforms, but the cryptococcal antigen test was negative. I'll come back to that later, why that has happened. But cryptococcal antigen was developed when they were when the world was investigating in the cryptococcal death prevention program, because in Africa, they saw a lot of deaths happening due to cryptococcal meningitis, but they didn't have a good test. So cryptococcal antigen is available as a lateral flow, which is like takes 10 minutes, and also latest agglutination test, which takes less than 24 hours, I presume. We, in our traditional teaching, we know that we can perform Indian stain in the CSF, which can have the characteristic appearance that you would see here, and also the culture, which will take days or weeks for the final results to come up. But cryptococcal antigen is transforming in that way. You can do in the serum, you can do in the CSF, and also it is detected in the serum roughly 22 days before the symptoms of meningitis appears. So it predates the onset of meningitis, cryptococcal meningitis. So you can diagnose well ahead and you can start treatment in these patients. So in this scenario, the cryptococcal antigen was negative and the blood cultures were negative. This is called as the prozone effect. As you can see in this diagram, when the antigen levels are low, the antibodies are in excess, it will become negative. And this is the typical the window that the cryptococcal antigen, the assay becomes positive. There's evidence of agglutination. But when the antigen is in excess, it does not agglutinate again, and it can give a false negative test, which is called as the prozone effect. And this is, if you dilute the test, if you do serial dilution, the test will become positive. And so as a protocol, when you suspect cryptococcal meningitis, you can have if it is negative, you can do serial dilutions. And in this patient, it happened, the sample became positive later. So cryptococcal disease, it can present, mainly occurs with the immunosuppressed, but it can occur in immunocompetent people as well. Mainly presents with meningoencephalitis, but can have pulmonary or disseminated forms. The treatment regime is complex, but it is given in a nice guideline, coined by the WHO, updated in 2018, I guess. So it mainly consists of using amphotericin B and flucytosine, and also there are 3 phases that you can use: induction phase, consolidation phase, and maintenance phase. And depending on that, the treatment is varied. I'm not going to discuss about Mycobacterial avium infections today. And regarding the learning points from this lecture, we are in a situation where there's a huge economic crisis in the country, and we might run out of medication, and we might not have fixed dose combination and single tablet combinations for HIV, because you give multiple medications as combinations in HIV to prevent resistance. So it is an important thing to know about this opportunistic infection. In case we run out, if the patients run out of tablets, we might see these patients more and more coming with opportunistic infections. So the most important way to prevent this is early diagnosis. Think about HIV early and start ARTs before, and rapid screening test for opportunistic infection is important, such as the beta-D-glucan, having cryptococcal antigens in board. Those would be important, but unfortunately, those are not in our armamentarium in our setting. But some of those tests are very cheap, so those we should embark on getting those things in case. I would like to ask for any questions, and also you could refer to this guideline. The HIV physicians have coined up this nice